It's time for another warm-up review. Let's get going. What drugs have each of the following side effects? So first we have agranulocytosis. Think about clozapine, carbamazepine, colchicine, propylthiouracil, and methimazole. Next we have osteoporosis. Think about corticosteroids and also long-term use of heparin. Next we have pulmonary fibrosis. Think about bleomycin and busulfan, which are both cancer drugs, but also think about amiodarone. Next is gynecomastia, which can be caused by spironolactone, THC, chronic alcohol use, cimetidine, ketoconazole, estrogens, and digoxin. Next, we have photosensitivity. So there's a mnemonic SAT for photo, which stands for sulfonamides, amiodarone, and tetracycline. And then drug-induced lupus, the mnemonic here is going to be SHIP, S-H-I-P-P, and that's going to be for sulfonamides, hydralazine, isoniazid, procainamide, and phenytoin. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're going to talk about edema and shock, which can both be thought of as derangements in hemodynamics. So let's talk about the forces that influence hemodynamics and fluid exchange in the capillaries. Now, this is a 5-star topic, very high yield for step 1, so make sure you understand these forces. When blood enters the capillary bed, fluid is moving out of the capillaries into the interstitium, and at the same time, fluid is moving back from the interstitium into the capillaries. Now, in an ideal system, the fluid moving out would exactly equal the fluid moving in, but in reality, not all the fluid makes it back into the venous system right away. That fluid stays in the interstitium, and it gets collected by the lymphatic vessels, and we call it lymph, and then it gets dumped back into the bloodstream down the road. And if you have too much lymph fluid building up in the interstitium, that's edema. Now, there are 4 basic forces that influence how much fluid moves out of the capillaries and how much moves back in. There's a place in your study guide for you to draw this diagram. You need to know what these 4 forces are and which direction they pull and push the fluid. First is PC, which is the capillary pressure, the hydrostatic pressure of the blood within the capillary. That's going to tend to push fluid out of the capillary. The second force is PI, the interstitial fluid pressure, which is pushing fluid back into the capillary. The third force is Pi-C, which is the colloid osmotic pressure of the plasma in the capillaries. C is for capillaries. This is due to the colloid in the plasma proteins. So those plasma proteins are going to exert an osmotic pressure that draws fluid from the interstitium into the capillaries. If you were to increase colloid in your blood, that would increase the plasma colloid osmotic pressure. And if you were to decrease colloid in the blood, that would decrease plasma colloid osmotic pressure. We'll talk about some conditions that cause this, but one example would be if you have nephrotic syndrome and you're losing a lot of protein in the urine, you're urinating out your plasma proteins. Then there's lower plasma colloid osmotic pressure, so more fluid is going to stay in the interstitium, which is why nephrotic syndrome causes edema. Then the fourth force is Pi-I, which is the colloid osmotic pressure of the interstitial fluid, and that's going to draw fluid out of the capillaries into the interstitium. So at the arterial end of the capillary, you tend to have a higher fluid to colloid ratio, and that causes fluid to leak from the capillary into the interstitium. At the venous end of the capillary fluid is a little more concentrated, a little more protein rich, so the colloid osmotic pressure is balanced out, so there's no net exchange at the end of the capillary. But at the beginning, you tend to draw fluid out because the osmotic pressure would be pulling fluid out of the capillary and into the interstitium. So again, make sure you understand these 4 forces. You've got the capillary pressure and the interstitial colloid osmotic pressure drawing fluid out of the capillary, and then you have the interstitial fluid pressure and the capillary colloid osmotic pressure drawing fluid back into the capillary. So make sure you understand those. There's another factor that affects capillary fluid dynamics you should know about, which is called the filtration constant, which we express as Kf. Kf is a measure of capillary permeability. Now, we're not going to do any calculations with Kf, but we are going to talk about conditions that increase or decrease capillary permeability, and therefore increase or decrease Kf. Now, one way you might be tested on this is if they describe a patient with some edema and they give you some diagnostic clues and they ask you what caused the edema, whether it was increased PC or decreased Pi-I or whatever. So, what conditions could cause increased capillary hydrostatic pressure, or increased PC, increased hydrostatic pressure inside the capillaries? Well, CHF is a big one because with right heart failure, the fluid's backing up from the heart into the venous circulation. which means that central venous pressure is going to be elevated. And that's going to increase the pressure at the venous end of the capillary, and the capillaries kind of become congested, hydrostatic pressure rises, and fluid is forced out of the capillary into the interstitium. So CHF is a big one. Venous thrombosis can also increase venous pressure locally, which is why a patient with a DVT in the leg is going to have edema in that leg. Or anything that compresses the veins, like a tumor or even restrictive clothing or a cast, anything that obstructs venous outflow. And finally, if you have sodium and water retention, either from kidney disease or increased activation of the renin-angiotensin-aldosterone system, that increased fluid volume is going to increase the central venous pressure and the capillary pressure, and that'll cause edema. A second major mechanism of edema is increased capillary permeability, because this increases that filtration constant, Kf. Now, septic shock will do this because of release of chemicals like histamine and bradykinin, which cause the capillaries to become leaky, which allows more fluid to leave the capillaries, and that leads to edema. And then certain toxins can do this as well, and so can burns. Now, a third mechanism of edema is decreased plasma colloid osmotic pressure, or decreased pi-C. We talked about how decreased plasma proteins like albumin could lower pi-C. For example, patients with liver disease may not be able to synthesize albumin. Or if a patient has protein malnutrition, where he's just not eating enough protein in order to have sufficient amino acid building blocks to make albumin. Or perhaps the patient is making plasma proteins, but then losing them. So we mentioned nephrotic syndrome as a cause of decreased plasma proteins. Or some patients have a protein-losing enteropathy, which is a small bowel problem where they're losing protein in the GI tract. And then the fourth mechanism is increased interstitial colloid osmotic pressure, increased pi-I. So instead of decreased protein in the blood, here we're talking about increased protein in the interstitium. And lymphatic obstruction is an example of this. Under normal circumstances, any plasma proteins that end up in the interstitium should be taken up by the lymphatics and pumped back into the circulation through the thoracic duct. But if the lymphatics are obstructed by a tumor or inflammation, or maybe following surgery or radiation that damages the lymphatics, but if for whatever reason the lymphatics are obstructed and those interstitial proteins don't get picked up by the lymphatics and they just stay in the interstitium, that's going to increase interstitial osmotic pressure. And on that note, let's briefly go over the difference between pitting versus non-pitting edema, because that's related to these interstitial proteins. Pitting edema is an edema caused by an excess amount of fluid in the absence of additional colloid. So it's kind of like a water balloon, just a sack of fluid, a bunch of fluid. Now, pitting edema is usually a gravity-dependent phenomenon, so it's often going to be seen down in the legs. So when you press on the patient's tibia, on the shin, it's going to leave an indentation or a pit, and that pit's going to stay there for several minutes after you remove your finger or your thumb, and that's called pitting edema. Now, non-pitting edema is where you press on the tibia, but there's no indentation left. And this occurs when there's a lot of colloid in the interstitial fluid, which balances out the excess interstitial fluid. Instead of being like a water balloon, it's more like Jell-O, where all that fluid is balanced by a lot of protein. So this balance of fluid and protein creates a semi-solid substance, kind of like Jell-O, and that colloid-rich edema won't pit. Another way to think about it is that the edema fluid from either increased capillary pressure or from decreased plasma proteins is basically just water. It's protein-poor fluid, and we call that a transudate. But edema fluid from increased capillary permeability is going to be protein-rich, because you're leaking fluid and protein alike into the interstitium. And this protein-rich fluid is called an exudate. Remember, exudate has extra stuff in it, like proteins and cells. Now let's talk about shock, which is another important disorder that's related to hemodynamics and capillary function. Shock is basically poor perfusion, typically either from cardiac failure or from vascular failure. And there are several different types of shock that you've got to be able to recognize. In your study guide, there's a table that says, how do systemic vascular resistance and cardiac output change in each of the following types of shock? The nice thing about shock is that it's very logical, and you can kind of reason your way through most of this. Hypovolemic shock might occur following trauma and massive blood loss. There's just less blood around for your heart to pump, so the cardiac output is decreased, and then the arteries are going to clamp down to try to raise the blood pressure, which increases the systemic vascular resistance. Then the treatment, obviously, is to replace fluids. You give IV fluids, most likely normal saline, 0.9% saline. And if you're giving blood products because of the trauma, that also will address the hypovolemia. The next one is cardiogenic shock. Now, what's the primary problem with cardiogenic shock? Well, the heart isn't pumping, so you have decreased cardiac output. Maybe you have a massive MI and the myocardium is stunned, or maybe you had a massive PE. So in either case, cardiac output is decreased. And then, how would you expect the body to respond to that? Again, systemic vascular resistance is going to increase. So with cardiogenic shock or heart failure, there's a compensatory increase in systemic vascular resistance. It's a compensatory mechanism. And then how do we treat this? Remember, inotropic drugs mostly, like dobutamine. The next category is septic shock. Now, sepsis can lead to vasodilation, which means SVR is decreased. You also have leaky capillaries and fluid moving into the interstitium, but vasodilation is the major component with decreased SVR. And the compensatory mechanism is to increase cardiac output. One of the earliest signs of septic shock is tachycardia. If you have a patient with fever, they just look pretty bad, and all of a sudden they become tachycardic, that would be very concerning that the patient's going into septic shock. It looks like the cardiac output is low because the blood pressure is falling, and the cardiac output is actually inadequate to perfuse the tissues, but the cardiac output is really elevated due to tachycardia. The treatment, of course, is antibiotics to treat the infection, and then you also need to fill up that dilated vascular space. Vascular resistance is decreased, and you want to fill up all that vascular space with IV fluids. So with septic shock, you bolus a lot of IV fluids. Then if you need to, you can also give a vasopressor to clamp down the vasculature. Now, which pressor is that? Norepinephrine. Norepinephrine is a drug of choice in septic shock if a vasopressor is needed at all. And also, be aware that septic shock can be complicated by multi-organ failure, renal failure, liver failure, pulmonary failure, ARDS. You can also get acute pancreatitis, adrenal insufficiency, and DIC. So just be aware that with severe sepsis, everything can start to shut down. And then one thing you'll see, not only with septic shock, but with other forms of shock as well, is that because you're not perfusing the tissues, you're not supplying them with the oxygen they need. So the tissues might shift into anaerobic metabolism and start producing lactate. So this can cause some lactic acidosis, which only makes things worse. The next one is anaphylactic shock, which looks a little bit like septic shock because the underlying cause is vasodilation again. Anaphylaxis occurs when the immune system is pre-sensitized to some allergen. When that allergen is encountered, there's degranulation of mast cells and basophils, and lots of vasoactive amines like histamine are released, and that causes massive vasodilation. So just like in septic shock, the SVR will fall and the cardiac output will rise to compensate. Then what's the treatment for anaphylaxis? Epinephrine. And then the last type of shock is neurogenic shock from something like a brain injury or a spinal cord injury. So the brain isn't communicating well with the heart and with the peripheral vasculature. So brain injury or spinal cord injury can cause neurogenic shock. You're going to see a decrease in both SVR and cardiac output. And again, the treatment here is to fill up the vascular space, so you give lots of IV fluids. And then with spinal cord injury, high-dose steroids are usually indicated to help reduce cord edema. You'll notice that in terms of SVR and cardiac output, both hypovolemic shock and cardiogenic shock look very much the same. So let's talk about what causes each of these and how you can tell them apart. The most obvious cause of hypovolemic shock is loss of blood. If you have a trauma patient who's in shock, you've got to think about blood loss and hypovolemic shock first. This can also occur in patients with severe burns. Burn patients can have a lot of insensible fluid loss, and that's going to cause a hypovolemic shock as well. And then what can cause cardiogenic shock? Well, we mentioned MI and pulmonary embolism already. CHF, obviously heart failure, can cause cardiogenic shock. And then so can life-threatening arrhythmias like ventricular tachycardia or ventricular fibrillation, where the heart's beating so fast that it's just not pumping anything forward. Cardiac tamponade can cause cardiogenic shock, and so can tension pneumothorax. And then cardiac contusion can cause cardiogenic shock as well. Shock can be very dangerous because patients can deteriorate rapidly over just a matter of hours. So these patients need to be monitored very closely in the ICU. Now, we've mentioned that you treat several different types of shock with lots of IV fluids and potentially some pressors, so these patients are usually going to need a central line. A central line is an IV catheter that goes into one of the central veins, like the subclavian vein or the internal jugular vein or the femoral vein. And technically, a central line is called a central venous catheter, or a CVC. Now, central lines can often remain in place a lot longer than a peripheral line can, and they also allow you to give more than one drug or fluid at a time. So let's look in the study guide and talk about the different sites where you can insert a central line. The femoral vein is a very easy place to start a line, but it usually can't stay in place more than 5 to 7 days due to risk of infection.
because it's located in the groin. Plus, patients can't really get out of bed and walk around or even sit up comfortably because they've got this big thing in the groin. And when patients are immobilized, they're more likely to get a DVT.
So let's take a quick detour and talk about the anatomy of the femoral region for just a moment. The important anatomy to know is the position of the vein relative to the artery and the nerve. You can use the mnemonic navel: nerve, artery, vein, empty space, and lymphatics. Now, almost everyone can remember that navel is the order, but sometimes in an emergency situation you forget which way the order goes. Is the nerve medial or lateral to the artery? Well, there are a couple of ways to help you remember this. One is that you go from lateral to medial to find the navel. So the order is going to be lateral to medial. Or you can remember the idea that dirty STDs need to be cleaned out by the lymphatics. So the lymphatics are the things that are closest to the genitalia. Or the way I learned it as a student was to think Navy, which stands for nerve, artery, vein, and yin-yang. Yin-yang means the genitals, which is kind of stupid and childish, but sometimes the childish, stupid stuff sticks in your brain, right? If you know the genitals are the yin-yang, then you know right away that the vein is medial to the artery. And then just a quick reminder that there's a tube of fascia kind of perpendicular to the inguinal ligament called the femoral sheath. And the artery and the vein are within the sheath, but the femoral nerve is outside the femoral sheath. It's pretty straightforward. Now, beyond knowing this for step one, why is this anatomy important clinically? Well, say you're trying to place a central line in the femoral vein. Well, you remember the mnemonic, and you know that the femoral vein is medial to the artery. So you palpate the femoral pulse, which is the artery, then you insert the needle 1 or 2 centimeters medial to that femoral arterial pulse. Now, if you get confused and you stick your needle lateral to the artery, what are you going to hit? The femoral nerve. And not only will you not get any blood back, but you might injure the nerve. So remember to palpate the artery and then insert the needle medial to the artery. So that's it for femoral lines. Let's go back to the study guide and wrap up the rest of these central line locations. The subclavian vein is preferred by some because it's easy to find and it can remain much longer for 3 to 4 weeks, and it's not as uncomfortable to the patient. But it has the highest risk of a pneumothorax, so it's not such a great choice in barrel-chested COPD patients or patients with lung tumors. And you always need to check a chest x-ray after you place the subclavian line to make sure there's no pneumothorax, and you also want to check the placement of the tip of the line. You don't want the tip of the line to be all the way down in the right ventricle. The internal jugular vein, or IJ, is a good choice because they're good landmarks, and it can usually remain in place for 3 to 4 weeks, but it can be a little more uncomfortable to the patient, plus there's a risk of puncturing the carotid artery or causing a pneumothorax. And with the left IJ line, there's a risk of perforating the left subclavian artery. Now it's time for the end of session quiz, so work through those questions, then we'll go over them together. First question, how does each of the following circumstances impact the Starling forces of fluid movement through the capillaries? So heart failure will lead to increased venous pressure, which gets translated back to the capillaries as increased hydrostatic pressure in the capillaries, and that pushes fluid out of the capillaries. So right heart failure can lead to peripheral edema, and left heart failure can lead to pulmonary edema. Liver failure will have a decrease in osmotic pressure in the capillaries because you're going to have decreased production of proteins. This decreased osmotic pressure allows fluid to leave the capillaries and stay in the interstitium. The next one is oliguric renal failure. Now with oliguria and fluid overload, there's going to be increased capillary pressure. Infections and toxins are going to increase capillary permeability. Nephrotic syndrome will result in the loss of plasma proteins and decrease the plasma colloid osmotic pressure. Lymphatic blockage causes protein retention in the tissues and the interstitium, and that increases interstitial osmotic pressure and draws fluid out of the capillaries and into the interstitium, resulting in non-pitting edema. Burns will increase capillary permeability, just like with infection and toxins. And in diuretic administration, the diuretic reduces the hydrostatic pressure in the capillaries, so less fluid is going to be forced out of the circulation and into the interstitium. IV infusion of albumin or clotting factors would increase plasma proteins and increase the plasma colloid osmotic pressure. And venous insufficiency increases capillary pressure and increases local edema. Next, how do the vascular resistance and stroke volume differ in hypovolemic shock compared to septic shock? Well, in hypovolemic shock, the stroke volume decreases and the vascular resistance increases to compensate for the drop in cardiac output. In septic shock, the vessels dilate and vascular resistance decreases. And then the heart attempts to compensate by increasing stroke volume and also increasing heart rate. Next, what are some of the causes of cardiogenic shock? So we talked about MI, PE, CHF, certain arrhythmias, cardiac tamponade, tension pneumothorax, and cardiac contusion. And the last one, how is the skin of a patient different in cardiogenic shock compared to septic shock? So in cardiogenic shock, the skin is typically cold, clammy, cyanotic, and poorly perfused. In septic shock, the skin is initially warm and flushed because of peripheral vasodilation, which is the main driving force in septic shock. And that's it for now. I'll see you next time.